President of CHSS, Dr. Georgios, President of ECHSA, Dr. Georgios Sarris, dear members of CHSS and members of ECHSA, colleagues, ladies and gentlemen. It is a great pleasure to introduce Georgios Sarris, the President of ECHSA, at the CHSS-ECHSA meeting, where two sister associations meet once again to reinforce legacies of science, respect and friendship across the Atlantic. The times of uncertainty and challenge we live now force us to connect virtually as a way to staying together. An example on how right visions and focused missions prevail over any adverse momentary circumstances. The shared vision and mission of my two beloved associations, as I'm privileged myself for being a member of both. Introducing George is an honor and a challenge. As I must disclose, George is an old friend of mine. I will start by George's roots and family to describe the man that stays behind the surgeon, then to profile the surgical leader that stands before all of us. George was born in Greece in 1956, being the son of two Carpathians, and Carpathos being an island in the beautiful Aegean Sea. His father was a doctor that unfortunately passed away when George was only 10, leaving her mother to raise their 4 children. Initially educated in Athens, he would leave to study in Harvard, from where he graduated in medicine. He attended the MIT doctoral program in health science and technology to receive later his PhD degree in medicine from the University of Athens. George's lonely days in Boston would be enlightened by Anna, a love for their entire lives. After concluding the internship in Boston, they would marry, still a running enterprise. And here we can see Anna telling George since their very beginning that the final word for the rest of their lives would be his own word, George's word. Yes, darling, you are absolutely right. They were blessed by 3 kids. Here Anna and George with their kids at their daughter's graduation. And here one of the boys in the army, not hunting ducks, but mostly likely watching out for the Turks. During his training in the US, George stayed at top places with the cream of cream, and that was the kickoff of a brilliant career. I always teach my residents that they will never excel at surgery without first being good persons. British poem named If by Rudyard Kipling provides the best ever description of a man. Poem celebrates lauding attributes of a man such as patience, courage, pragmatic thinking, capability, independence, and leadership. These attributes are all to be recognized in George's character and stand behind the surgeon that is, above all, an excellent person. I will now describe George as an academic surgeon. My former mentor, Mark Laval, defined academic surgeons as shining in clinical practice, research, education, administration, and leadership. Well, George is a talented congenital heart surgeon with excellent results. For a few of us working in deprived setups, climbing the tree of success takes as much sweat as it does for technical expertise. George, you succeeded where many of us would just give up. Here are his results and professional affiliations. George debuted medical research soon. Here we can see him in Greg's Miller research lab, and his remarkable contributions in our field, namely for ECHSA multicentric studies. His H-index and citation tolls are quite impressive. And innovative artificial intelligence methods for outcome analysis constitute his most recent interest, soon to be published. Teaching is another of George's interests. Here in Athens, with me and other colleagues at a hands-on course on surgery for transposition. Well, George is a good manager, from chief of department in Athens to secretary and member of ECHSA's executive committee, and now as ECHSA's president. Here during our busy executive committee meetings, working hard with Charles Keebles, our treasurer, and myself, still as president. George, I do miss those meetings a lot, and not only for the beer. Well, leadership is a value in greatest need presently. George Sarris is a leader. He is a leader for his character and personality that I described along with Kipling's poem. But leadership nourishes itself on a blend of profiles: the artist, the craftsman, and the technocrat. George has the vision and creativity of the artist, possesses the knowledge and the realism of the craftsman, and when needed, vests the organized pragmatism of a technocrat. We all know that the heroism of leadership that many of us saw in our mentors as a common denominator, the fact that all of them, despite the charisma of artists, the candor and the technical brilliance of their craftsmanship, were exceptional human beings. Now, George, networking with a lot of friends, I think in Greece, now in Lisbon, while we were sailing, in the States, in Santorini, in Cascais, when I stepped down for president with many of our friends. And ladies and gentlemen, it is my honor to introduce our president, a surgical leader, but first and above all, an exceptional human being, George Sarris. Thank you.
Dear colleagues, first, I would like to thank José Fragata for his most kind, generous, and favorably exaggerated introduction. José's leadership of ECHSA as the immediate past president has been landmark. Succeeding him as president of ECHSA has been the greatest honor of my professional life, and it remains a daunting task to even attempt to match his contributions to our association. In thinking about my presentation today, I have tried to look towards the future, not just of ECHSA, but of our subspecialty as a whole. I was stimulated by my experience of close collaboration with the artificial intelligence team of Professor Bertsimas at MIT during this entire past year, working to use machine learning, analyzing congenital heart surgery data. Thus, I decided to attempt to provide you with an overview of the fantastic opportunities and challenges provided to our specialty by the explosive progress of artificial intelligence. Of course, I wish to emphasize that I am by no means an expert on AI. Therefore, this presentation provides only the perspective of a clinical pediatric cardiac surgeon wondering if and how the impressive achievements and capabilities of AI could be harnessed for the benefit of our patients. In a paper called Medicine and the Computer, published in the New England Journal of Medicine some 50 years ago, Dr. Schwartz predicted that computing science will probably exert its major effects by augmenting and, in some cases, largely replacing the intellectual functions of the physician. As I will be showing you, this prediction has been proven largely correct, and in fact, the impact of artificial intelligence in medicine is even bolder. Increasingly, this dream is becoming to create a virtual global team of medical experts holding the ever-expanding accumulated wisdom of the decisions of millions of physicians regarding the medical issues and resulting outcomes of billions of patients. This virtual global artificial intelligence team will then be able to support the decision of every physician with real-time personalized advice on the diagnosis, management, and actual therapy of each patient. Before we consider whether such far-reaching promise is conceivably possible, some definitions are in order. Artificial intelligence is defined by Encyclopedia Britannica as the ability of a digital computer or a computer-controlled robot to perform tasks commonly associated with intelligent beings. This term was coined by John McCarthy in preparation for a Dartmouth summer research project back in 1965. And he stated that the study was to proceed on the basis that every aspect of learning or any other feature of intelligence can in principle be so precisely described that a machine can be made to simulate it. Pivotal in all these achievements has been the development of what has become known as machine learning, which is the application of AI systems to learn and improve from experience without being explicitly programmed to do particular tasks. Humans can learn to make general complex associations from small amounts of data. For example, a toddler learning to recognize a cat, whereas machines require many more examples and do not have common sense. They do not have what Michael Polanyi described as tacit or implicit understanding. Yet, although machines need massive amounts of data to learn from, their ability to absorb such data is practically limitless, and they do not tire. Of course, there are too many types of machine learning for a non-expert to understand and describe, but it is useful to distinguish between two general categories. In the supervised models, data sets are prepared and labeled by humans according to predefined categories, and the relevant algorithms are designed to orient only to categories and concepts pre-specified by us. In unsupervised models, pattern recognition is allowed to develop freely within the data, with algorithms learning without human-provided guidance. Looking at AI history, it is interesting that the subject of whether machines can be made to think has been considered in the 17th century by the French philosopher René Descartes in his 1637 book Discourse, a book famous for the quote, "Cogito ergo sum," I think, therefore I am. Descartes seems to have predicted that some machines could be made able to perform tasks as well as, or even better than humans, but he felt they could neither be made to talk nor to perform tasks based on understanding. Obviously, he was wrong on the first prediction, machines talking, and his second is being seriously challenged. Of the many exciting milestones of AI, too numerous to describe in this talk, I will mention just a few. The field may be said to have its foundations on a famous paper on computable numbers by the British mathematician Alan Turing back in 1936. Other milestones: in 1964 at MIT, Joseph Weizenbaum created the first chatbot called ELIZA, which could fool users into believing that they were conversing with a human rather than with a computer. By 1997, IBM's Deep Blue computer defeated the chess world champion Garry Kasparov, stunning the world. In the next decade, progress was even more rapid. In 2004, the first self-driving vehicle competition was launched in the Mojave Desert. This is the Carnegie Mellon team. In 2011, IBM Watson computer defeated the then famous Jeopardy champions. In 2012, the famous paper on successful image recognition using ImageNet data was published, and within 3 years only, it was demonstrated that machines could recognize images better than humans. And in 2018, self-driving cars appeared in the streets. These achievements of AI, boosted by the availability of huge amounts of data, are staggering. So much so that Klaus Schwab, the founder and executive chairman of the World Economic Forum, introduced the term fourth industrial revolution of AI as the theme of the 2016 forum held in Davos. This fourth industrial revolution of AI was described to follow the sequence of the first involving steam machines, the second involving electricity and the telegraph, and the third, that of automated production, electronics, and computers. But has medicine in general profited from this fourth industrial revolution, as predicted in the 1970 New England Journal of Medicine paper? The answer is clearly affirmative. Back in the 70s, computers in medicine involved only programming specific rules. Today, AI models have evolved to learn from examples provided as inputs, so-called features, and outputs called labels. The machines learn how to map features to labels and can perform this task with new, previously unseen inputs, finding statistical patterns over millions of examples of features and labels. There are many achievements of AI in medicine. Most notably, they involve image and other pattern recognition in specialized applications. Machines can interpret medical images such as chest X-rays, CT scans, in fact, recently looking for signs of COVID-19 infection, or mammograms. They can read pathology slides of biopsy specimen, diagnose eye conditions based on retinal images, diagnose skin cancer based on photos of skin lesions, and they can even diagnose syndromic phenotypes based on facial photographs. There are other applications of AI in medicine in the field of genomics, where systems analyze huge data sets of DNA data to identify disease-related genes, aiming to achieve precision, personalized medical diagnosis and therapy. Now, all these achievements described can be thought of as applications of so-called narrow AI, as opposed to the more general and even more ambitious applications envisioned by Eric Topol in his book, Deep Medicine. This far-reaching vision of deep medicine involves eventually digitizing all relevant patient data, from anatomy to genetics, a process he described as deep phenotyping. This data set would then permit AI algorithms to provide full diagnostic and therapeutic assistance to the physician. And it is this strategic direction that was taken by IBM's Watson Health Division, aiming to provide decision support for physicians via analysis of massive data sets. IBM invested $1 billion in 2014 in its Watson unit and spent another $4 billion a couple of years later acquiring several health data companies. Nevertheless, successes in this mega project have been rather limited. Of many projects, ranging from management of diabetes to drug development, only the Watson for Genomics tool for cancer has reached maturity. Clearly, AI still faces major challenges in achieving tasks which physicians can still do better. But let's take a look at tangible, practically useful AI-based cardiovascular applications. Again, those involving image analysis are most prominent. For example, the risk of ischemic events may be predicted from automated analysis of CT coronary angiograms, or the Ultromix stress echo analysis system can help diagnose myocardial ischemia by automatic detection of LV wall motion abnormalities, even subtle ones. Risk prediction seems to be one of the most important areas where AI technology can provide very useful assistance. For example, machine learning algorithms analyzing Medicare data were able to identify preoperative risk factors associated with negative outcomes and superutilization of medical expenditures postoperatively. Not surprisingly, a startup company raised many $millions to develop machine learning systems predicting which individuals are likely to require high-cost care. As for specific cardiac problems, machine learning deep neural network methodology has successfully predicted risk after the Norwood operation with excellent accuracy. If we go down to individual patient level, for clinicians managing sick patients under considerable time pressure, as we all are, AI was shown to predict over 90% of all acute kidney injuries requiring subsequent dialysis with a lead time of up to 48 hours. This would enable measures to prevent the need for dialysis. Another machine learning-based algorithm has served as a warning system for prediction of serious intraoperative hypotension. Unfortunately, for the technical part of the work of a surgeon, the promise of AI still remains largely a promise. Robotically assisted surgery has been available for some time, but it has been mostly useful for specialties other than cardiovascular surgery and certainly pediatric cardiac surgery. Still, there are some new, very ambitious AI-based surgical platforms in the works. The Verb surgical system is being developed jointly by Google and Johnson & Johnson. It is envisioned as a totally robotic platform with all robots interconnected via the internet, integrating VR data and deploying machine learning analysis of all patient information. Another important issue is accountability, especially for medical applications. An error committed by a physician may lead to major adverse consequences, but these are typically more limited to one or perhaps a few patients. In contrast, a faulty algorithm leading to erroneous recommendations, for example in drug therapy, may have very widespread adverse impact. It is clear that doctors, hospitals, and health systems remain accountable for decisions made based on machine predictions and recommendations. It is our accountability towards our patients which underlies our need for interpretability. We need to understand, to interpret appropriately machine-based recommendations. It should be noted along these lines that the inner workings of many machine learning algorithms, such as deep neural networks, are so complex that it may be nearly impossible to understand how their specific output or a specific prediction was made, even for AI experts. For this reason, such models are characterized as black boxes, and importantly, the AI Now Institute recommends that for any high-stakes matter, including healthcare, we should not rely on black box AI. We can be helped by it. The European Union General Data Protection Regulation, introduced a couple of years ago, requires companies to give users an explanation for decisions made by automated systems. In the US, the FDA is developing a regulatory framework for AI software which can be labeled software as medical devices if they are intended to diagnose, treat, or prevent disease. Fortunately, there are AI and machine learning-based methodologies which are definitely not black box methods, but instead offer full intuitive interpretability of their output. For example, Dimitris Pertsimas and his team at MIT has developed a machine learning method known as optimal classification trees, and he has applied this to various medical settings. In one of these, he has used OCTs to develop highly accurate models for predicting risk in emergency surgery. Now, the workings of how the OCT algorithms reach recommendations are fully transparent to physicians, and therefore they can trust the machine recommendations. So what about possible specific applications of AI in congenital heart surgery? First, there are numerous possibilities leveraging the strengths of AI in image analysis. Imagine, for example, a pediatric cardiology, pediatric cardiac surgical conference discussing a complex patient. An appropriate AI system could have integrated all the available information from modalities including CT, MRI, echoes, angios, could have performed automatic segmentation of images and produced patient-specific 3D models, both virtual and automatically printed physical ones. These models could then be readily used for surgical decision-making, planning, and preoperative simulation. Also, intraoperative management could benefit by AI-based analysis and fine-tuning of anesthesia and perfusion parameters to optimize outcome, minimizing risk. The surgical procedure itself could also receive multimodality support in the form of machine learning-based integrated advanced imaging technologies as envisioned in the Google Verb surgical system I described earlier. Postoperative care could also benefit from AI-powered multi-parameter monitoring and analysis aiming for optimization of hemodynamics recommendations and for real-time adverse event prediction. I would love to see a system which would predict accurately and therefore help prevent certain very unpleasant events which probably most of us have regrettably faced. For example, the dreaded, otherwise unexplained sudden cardiac arrest in the pediatric cardiac ICU. Now, these exciting applications are possible given data and effort, but they are still not available now. What are available now, however, are very powerful and very versatile machine learning-based tools for predicting risks in congenital heart surgery. For example, our multidisciplinary team effort bringing together the ECHSA congenital database and the data analytics team of MIT and Alexandria Health, led by Professor Dimitris Pertsimas, has developed highly accurate nonlinear risk models for predicting outcomes after congenital heart surgery. Importantly, the predictions of the models are fully transparent to the physicians and they are fully interpretable. Based on these models, which present themselves as decision trees, a user-friendly calculator for predicting risks of individual patients based on their preoperative profile was also developed. Our preliminary results in these efforts, which had been accepted for presentation at the AATS meeting last May, which was cancelled, are currently under independent review. To summarize, the promise of AI in medicine is enormous, ranging from achieving unprecedented diagnostic accuracy and efficiency to optimize decision-making and to provision of optimal treatment recommendations, even of specific therapy support. This promise can also be fully realized in our field of congenital heart surgery, and the potential benefits for our patients are huge. Still, achieving these goals will not be accomplished without major efforts. The challenges are great, but congenital heart surgeons have historically proven that they do not shy from effort, nor do they fear change. On the contrary, our history is built on bold innovation. Furthermore, our culture is that of multidisciplinary cooperation, and this particular frontier requires even closer cooperation of very different disciplines. It is important that we cooperate closely with our partners in the computer science world and to become actively engaged in these joint efforts. Artificial intelligence depends on the collection and availability of large amounts of high-quality data which are collected by us humans. We should make sincere efforts to cooperate, unifying valuable data scattered in various databases around the world, making them available for research. It is important to avoid infusing data with human biases and to avoid the pitfall of having machines learn from erroneous human practices of the past. We must understand the limitations of this exciting and powerful technology so that we can interpret its output intelligently. We should understand the need for and participate in the development of necessary and reasonable oversights. It is clear that computers are becoming unmatched experts at thousands of specific tasks, and that their assistance and support will definitely become ever more important in our practice. For the moment, it appears that computers are lagging behind in the so-called general intelligence and cannot be substitutes for physicians. The doctor-patient relationship will remain the cornerstone and guarantor of excellent care, which will undoubtedly be enriched by the deep insights of machine learning and further empowered by the remarkable achievements of AI. Clearly, the responsibility for our patients continues to be ours alone. Our practice is and will always continue to be guided by our Hippocratic oath. I would like to conclude with a favorite quote attributed to Albert Einstein. Life is like riding a bicycle. To keep your balance, you must keep going. I thank you very much for your attention.
George, thank you so much for this brilliant and intriguing ECHSA presidential address, and to Jose Fragata, of course, for such a heartfelt introduction.